Thank you so much, Mitch. So first, I would be remiss if I did not take a second to just applaud the keynote address that you just heard. Joe is just phenomenal. Dr. Smizer is just phenomenal. And I've worked with him for many years, and I'm just amazed at his insights that he is always able to share, relevant, timely, and just inspiring. And so I felt pumped up myself as a public health official that has been in this space of working with New Jersey's Department of Health for 20 years. This is my 20th year. And so I'm just going to slide right into my presentation, and hopefully some of the information that I share with you will help to inform how we reach vulnerable populations, and specifically how we overcome some of the barriers of misinformation that were described by Joe. And again, kudos to my friend for such a great presentation. So first, I want to outline what the purpose of my presentation is. I'm going to very briefly describe the Division of Community Health Services, which is the division within the department that I oversee, and how it fits within a broader scheme of addressing health disparities within the Department of Health. Then I would like to describe what is meant by equity and social determinants of health. Next, to provide some of the key terms that you'll find throughout my presentation, provide key data points that illustrate some of the challenges that we're up against, not just COVID, but some of the other challenges that were exposed by virtue of some of what we've seen with COVID-19. But it exposed a lot of what we in public health already knew were problems and challenges for decades. Some of the lessons learned from COVID-19, and then some strategies that could help to improve outcomes for populations that we know to be vulnerable in this state of New Jersey. I know that Mitch in the beginning gave some disclosure statements, but here is mine, that I have no financial interest in the sponsoring agency Rutgers School of Public Health. I have no conflict of interest also. So now let's talk about the Division of Community Health Services. The division came into being, it was birthed in December of 2017. It was at the end of the Chris Christie administration that the New Jersey Department of Health was reorganized. And the goal was to create a new branch. The new branch is Integrated Health Services. And within that branch, there are two divisions, two primary divisions, the Division of Behavioral Health Services and the Division of Community Health Services. So within my division, there are three major units: the Office of Primary Care and Rural Health, Oral Health Services, and Community Health and Wellness. So let me talk just briefly about each of these. The Office of Primary Care and Rural Health is designed to be a resource to New Jersey residents to ensure that every resident of the state has access to care, whether we're talking about rural parts of the state, the more urban communities, suburbs, exurbs, any area of New Jersey. New Jersey, we know, is a very varied state, even though it is a very densely populated and small geographic state. It has the highest number of people per square mile of any state in the country, and our landscape is so very different. We have mountains, we have beaches, we have, you know, farms galore throughout the state. We have industrial sections of the state and everything in between. And so the office is designed to ensure that we have robust relationships with community partners. Federally qualified health centers are among them. There are 23 of them licensed in the state with over 130 sites. And through the division, through the Office of Primary Care and Rural Health, we manage what is called the Uncompensated Care Fund. That allows us to be able to provide reimbursement to FQHCs, federally qualified health centers, for delivering care, whether physical health, behavioral health, or dental health services to those who are uninsured and underinsured. Along with that, we are a resource for bringing resources to New Jersey. Joe talked about the impact that these past years have had on public health, and they have had a tremendous impact, but they've also had an impact on our safety net for providing care out in the community. And so we've lost a lot of individuals in the nursing profession, doctors, we've lost some of the paraprofessionals. And what we do in the Office of Primary Care and Rural Health is to bring resources to New Jersey. We oversee a number of programs that are incentive programs for practitioners, including the loan redemption program, where we help providers to pay off their student debt for their medical education, nurses, doctors, psychiatrists, and the list goes on. We oversee the J-1 visa waiver program for foreign doctors that want to work and stay in the United States. In exchange, they are required to work in communities that are vulnerable. We also have responsibility for manning a system that is called the 3RNet system. That's a portal that is free that allows for individuals who are looking for employment in the health professions to be able to post their resumes, their CVs, and for employers to post job openings. It is an exchange platform that the federal government pays for that allows for different states to have people know where opportunity lies. And we recently hired staff to man that system on a regular basis. New Jersey really had not done that in the past. In oral health services, I think it is critically important that we think about the connection between one's oral health and overall health. In my first year of being assistant commissioner, we applied for and were awarded a grant to be able to onboard a dental director for New Jersey. We hadn't had one in 30 years. And so it allows us to be able to focus on oral health and its connection to other health concerns. We also have a number of programs there to work with young people around oral health education and some interventions. We're currently, for instance, running a fluoride varnish program to assist young people to make sure that their teeth are strong, their gums are strong. We're working right now, awaiting a word on our most recent grant application that we've made to HRSA, the Health Resources and Services Administration, which will, if funded, allow us to roll out the first ever dental sealant program in New Jersey. We recently have begun to roll out our basic screening survey, which will allow for those who are all about data to have surveillance on oral health in New Jersey. We are one of only 3 states in the nation that have not been participating in the CDC recommended basic screening survey. Next, a community health and wellness unit is focused on chronic conditions. So that's everything from asthma, cancer, heart disease, diabetes, the lesser known programs such as ALS, cystic fibrosis, chronic renal, Huntington's disease. And we have, importantly, one of Joe's favorite areas that we've worked with him on, tobacco prevention and control. We also have been working in the space of obesity prevention and control, where he's also been doing great work around sweetened beverages. So let's move now forward. Now that you know a bit about what my unit, my division does, we work collaboratively with a number of other units that are focused on equity. And some of them include the Division of Epidemiology, Environmental and Occupational Health, Division of Family Health Services, Division of HIV, AIDS, STD, TB Services, the Office of Population Health, and the Office of Minority and Multicultural Health. These are some key terms that I want for us to all just get into our heads, our psyche as I'm talking, because they are in integral parts of this presentation. First, implicit and bias. You've heard these terms kicked around quite a bit in public health, but seeing them spelled out in definition form gives you a sense of, where what we're talking about when we use the phrase implicit bias, as well as racism, which we sometimes shy away from, but we have to dispel this notion that using honest, truthful, transparent words is going to derail us. No, we need to speak honestly about the things that are holding up progress. And I love Dr. Halkitis because he is not a shy person. Anyone who has ever read any of his op-eds, anyone who has read even the research-based articles that he's put forth, he doesn't shirk from speaking in terms that are very clear and honest. And we must as public health officials. So this is a slide that really gets to just a graphic depiction of the difference between equality and equity. Many of you have probably already seen this. The one image on the left has a group of guys who are trying to see a baseball game. The poor short guy can't see anything, seeing a fence. And the other two are varying stages. They all have the same prop, but that equality does not equal them having an equitable experience. The next slide, though, is one that I want to draw your attention to. And this is really important because I like, number one, looking at what is the reality? What are we seeing today? And what we see today that we need to address in many of these instances is that picture of the guy that's just, number one, he's shorter than the other guys, but he's also dug down into the ground. And so he has a long way to go before there is an equitable situation for him. And then the one guy who is the tallest of the guys watching the baseball game happens to be propped up way up. And that's the reality, is that those who have are far outpacing those that don't have. And it's our job in public health to make sure that we address that. But our ultimate goal is to get to a place where there's liberation, where there's no need for anyone to have a prop, where everyone is in a position where there is that seamless and equal access that they need to the things that are important to their lives. We all have in public health come to the realization that there are determinants of health that fall outside of health systems. And this diagram just shows some of the inputs that are really important to understanding why there are such big gaps in access to the resources that we need, especially in the midst of a pandemic. And some of them include, public safety differences, transportation, education, employment, health system, and services access. We found that even in communities that are well stocked with other resources, they may be lacking health systems and health services access. Housing is very often an issue. Income and wealth is a huge determinant. And the physical and social environments are all very important to determining whether someone is going to be able to have the resources that they need in order to be successful in their own quest for good, strong health. Now, this slide is one that I think is important because as we just left the one slide talking about the determinants of health, we have to realize that there are such varied housing realities that people live through. And I wanted to show this slide for a couple of reasons. Number one, all of them are pictures from New Jersey. These are not from other states. These are not from another country. But the slide shows something that was very reminiscent for me personally. So in the top right-hand corner, there are a row of what I call shacks. Um, this row of shacks it looks as if it is actually a real picture of the type of housing that my mother grew up in. My mother grew up in Monmouth County, and she grew up in a one-room shack with a dirt floor, no indoor plumbing, uh, in New Jersey. And my grandfather, uh, her father, was a union worker all of his life. He was not a unemployed individual who just happened to just live in a shack. He was a worker his entire life, and he and my grandmother had 8 children. And if you could imagine, um, even 4 people living in one room of a shack that looks like this, the least of their concerns was their health. And by that, I mean preventive health. As I was growing up, my grandparents and their siblings, my great aunts and uncles, I thought it was normal that everyone had sugar, everyone had high blood pressure, everyone had full sets of dentures, and that was the norm. It was the way that I thought that people progressed in their lives when they reached around 40. It was like near the end, I'm sorry. And so I was thinking that that was the way things were. And it wasn't until I started to mature and attend college and to learn more in the space of public health that I came to understand that while they lived in a state that is very wealthy, New Jersey is a very wealthy state, the disparities are wide. And so just a mere mile or so from my mother's parents were my father's parents. Now, my grandfather on my father's side worked for the New Jersey Turnpike, the Turnpike Authority, and they owned a house that resembled the house that's in the middle at the top. And they had, my father's one of 16. So huge families uh, on both sides of my family, but the differences stark between them. And how you approach your health can be dictated very, very strongly by where you live. And final point that I'll raise here is that redlining and some of the decisions that had been made in the the finance sector had extremely detrimental impact on already vulnerable populations. So I now give a warning because I'm going to venture into some slides that are graphic, and I wanted to make sure that people were aware that there are going to be some graphic depictions that come forward, but they're important to give context to where we are and where we have been. So we don't always delve into how horrible the history has been in this country when it comes to people of color. Now, my slides will focus on the Black population, but the same could be said for some of the discriminatory practices to the Asian population. The same could be said, and especially more recently, to the Latino population, and to some degrees, even lesser degrees though, to uh, subsets of the European population, whether you're talking about Irish Americans or Italian Americans. So we know that over 400 years ago, slaves were formally being brought to these United States and forced to provide labor. That labor built this country. There's no doubt about it that the labor of forced slavery led to this country becoming the great nation that it is today. Some of the things to note is that it wasn't until around the 1800s that we started seeing movement in addressing this horrible history of slavery. And the depiction on the left is of a slave who went by the name of Gordon. This is from about 1863. This picture went around, it would be the equivalent of viral Instagram or tweets that we know of today, but this went around, this picture, and was created much of a groundswell around what was already moving forward around the emancipation of slaveries. And we all know that in 1865 that emancipation came, but that wasn't the end of the story. On the right, you see an image of the backlash, some of the backlash. You see a whole bunch of smiling faces there of people as there's a body of a Black person who has been lynched. And this is from 1919. Now we move forward. Of course, after emancipation, there was strong pushback and there was segregation that we saw in this country that was institutionalized. But I put a question mark about until, because in many ways, our society is still very segregated. There are still communities that are considered predominantly Black, communities that are considered predominantly white, and the litany goes on. In 1963, you have Bloody Sunday in Selma. A lot of this led to a lot of the peaceful demonstrations led to the civil rights enactments that came thereafter. But we cannot leave some of our history unspoken when it comes to human experimentation and its impact on public health. Many are aware that there are instances where Black people were subject to research, many of them without their consent and without proper care and treatment during the experimentation. Henrietta Lacks, her cells were used for studying cancer without her permission. This is out of Johns Hopkins University. These cells, even to this day, are pioneering and have been used for the study of cancer and have led to many breakthroughs. But again, this was without her permission or her family's permission. Dr. James Marion Sims is known as the basically the father of OBGYN care, and he experimented on slave women, basically mutilating their privates, their reproductive organs in order to make gains. And those gains have no doubt made a huge impact on the quality of care that we know of today. But it was at the expense of these Black women. In the Tuskegee experiment, we know that over a 40-year period, Black men were, by this government, were subject to experimentation. They were known to have syphilis and were not given treatment even after treatment was known to be effective. These are not going to bode well for bolstering confidence. What has happened in our more recent days? We have had a the prison industrial complex where school to prison has been something that has been prevalent within Black and brown communities. We see in the depiction on the right, a homeless Black woman being beaten brutally by police officers because she happened to be homeless. She walked into the store, she did not steal anything, but the person did not want this homeless person there. They thought they were calling the police. The story goes that they thought they were calling the police so that the police could just usher her out, not beat her. And then there's a 10-year-old child being restrained by police. I won't dwell too heavily on the killing of George Floyd that we all witnessed. And cringed at, but also just the sheer nature of the brutality of someone dying because of an accusation that they used a forged $20 bill. Um, these realities have an impact on trust. They absolutely erode trust. But it's not just that. It is incredible to note that there was multiracial, multi-generational response to the killing of George Floyd that showed signs of the unification of people around what was truly an unjust situation. Obviously, people of all colors, races, ages saw it and were appalled. But they were met with um, force that was unbelievable on the side of law enforcement because they were voicing their uh, concern about an unjust reality. But what did we see also taking place in society? We saw individuals storm our Capitol, and we saw them desecrate the Capitol. We saw the death of law enforcement at the hands of these individuals. And immediately following the insurrection, very few were arrested. They left. They were allowed to leave. And it was only after when there was such an outcry by the public, like what is going on, that you saw people being prosecuted by our federal government. Again, none of this builds confidence. Why is this relevant to this presentation? Because in the context of the society within which we live, we have to deliver care. And so when we say to people as government officials to trust us, it's hard to have a sense of trust when these are the realities that you see in the day-to-day lives of vulnerable populations. The American Heart Association tried to capture what it means to see the intersection between structural racism and health. And this diagram is very helpful to me to look at because it takes you through all of the basic slides that I've shared, and you get to this section of the presentation of their slide, and it leads to poor access to healthcare, poor housing conditions and physical environment, poorly funded schools, poor access to capital. Those sound like the determinants of health that we talked about earlier. All of it feeds to the same result, and that is poor outcomes. Now here we have some of the examples of some of the disparities in health that we unfortunately see. Healthcare among people of color compared to white people. The orange color depicts worse. And again, this is as compared to white people. And the light blue is no difference, and the darker blue is better. So 9% of respondents to this indicated that they felt their health and health care were better than that of white in the Black community. 15% uh, is measured by the Hispanic. Then you go across and you have Asian, American Indian, Native American. And so what I found very interesting about this is that 44% said that it was worse. 44 measures, I'm sorry. There were a total number of measures. My apologies, I'm misstating what this is. There were measures that were across all of these groups. There were, I think it was 59 measures for all of them. And as you look at the numbers of those measures, 44 of the measures, Black said that they were worse than whites. 38 measures for Hispanic, only 13 for Asian, and 34 for American Indian or Native American. Now you look at the age distribution of the various races, and this was disturbing for me because it shows you that within the Black population, the greater proportions of our population that live to the 65 and older is going to be among the white population. When it comes to Black, you have the greatest number is within the youngest group of 0 to 18, and then within the 35 to 54. But the numbers dramatically decline at the top of that scale. And you can look across and see the other racial and ethnic groups. This is a busy slide, and so I'll just try to summarize. It's depicting the difference between causation of environmental issues and exposure to environmental toxins and issues. And as you can see within the Black community causes less than the average on environmental outputs, and then is exposed far higher. You look at Hispanic, they cause even less, but they are also exposed to higher than average. And within the white community, however, the cause of environmental problems is higher than exposure. These are some of the areas of public health that we have focused on within our state health department. And I'll quickly go through some of these slides. Like for instance, the rate of asthma-related hospitalizations was 135 per 100,000 in white residents, yet it was 984 per 100,000 in Black residents. Breast cancer, white women, it's 41.3 per 100,000 for late stage detection, and 46 per 100,000 for Black women. Cardiovascular disease. The impact here is that the death rate of white and Black residents was outpaced by Hispanics, 91.1 per 100,000, and Asian is 64.6 per 100,000. White residents for that same period was 169.4 per 100,000, and for Black was 183.6. Diabetes, a similar story, almost double, well, a little more than, or just at double, the rate of mortality related to diabetes in Black as compared to white. And then when we look at HIV, AIDS, 8.1 per 100,000 Black residents, 8.1, as compared to 0.5 per 100,000 for white and 1.5 per 100,000 Hispanic residents. And then finally, obesity. There's disparity there. Violence can never go unspoken about as a public health crisis. Data reveals that for Blacks, the homicide rate between 2017 and 2019, 16.5 per 100,000, which is more than 5 times that for the Hispanic population, which is 3.2 per 100,000, and 17 times that of white, which is 1 per 100,000. And then firearm homicide disproportionately impacting Blacks as well. And then figures are there. Finally, overdose, which is another pandemic that we have been struggling through and has gotten worse during this COVID pandemic. Infant mortality is one that we've been focusing in on most recently, and maternal mortality, where we have seen higher rates of death among Black babies and Black mothers. And we would be remiss if we did not touch upon these. And of course, uh, harkening back to what we talked about with the Tuskegee experiment, there are higher rates that we're seeing right now in sexually transmitted diseases within communities of color. Now, how would any of this affect vaccine hesitancy? I would dare say that it absolutely has an impact. Um, and this continuum shows you where things could lie on that scale, where there's high demand for the vaccine, passive acceptance, and then as you go further to the left, refuse the vaccines. How do we instill confidence in vaccines? Number one, we have to be transparent, and we have to, as Joe indicated, and I think Perry as well, that we've got to be honest. We have to share with people what we know, and we have to be transparent with the information and not keep things bottled up, nor do we leave it to uh, just certain officials within an organization to be able to speak out about the importance of this public health initiative when we're talking about vaccines. The engagement of the public, here we should be listening. We should be listening. We should be listening to the public about what the public's concerns are. We should not assume that we know as public health officials what resonates with every person, but we should be listening to all corners of society. We should be listening to our LGBTQI brothers and sisters, and always open and receptive to populations that are usually not reached out to. Our homeless community we needed to talk with during this pandemic. Our incarcerated population, we needed to learn what was needed in that segment of our society. It's always critical that we have our ears open to understanding what the needs are and how best to address those needs. That leads to making sure that we're culturally and linguistically competent in what we're sending out in our messaging. And then we need to recruit and utilize community influencers, but not for the sake of using them and then dispatching them back out. They need to be a part of our growing need for public health workforce. They need to be individuals that have an ability to rise through the ranks and to become the leaders within public health. Some of the strategies that we've used here at the department that have been hugely successful is listed. These are listed here. The COVID-19 Information Hub is a portal online where we've been sharing information with the public since the beginning, before there was even a vaccine available. We stood up mega sites across the state, but those mega sites were not always accessible for everyone. So what did we do? We retained some federal resources. We started working with churches within communities that were particularly vulnerable, and FEMA came in, they staffed those churches. They actually were administering vaccines, and we brought together community members, local public health officials, and we registered people, brought them in large numbers. I was at those sites in those early days, and we were consistently seeing lines around the corner when people were saying, Black people aren't going to get a vaccine. Brown people aren't going to get a vaccine. Yes, they would, once we made it available and accessible. We created vulnerable community work groups. We stood up what the commissioner calls vaccine ambassadors. I'm one of them. I have been for the past year and a half. Grateful for the Shot is an initiative that I oversee with funding from the Pandemic Relief Fund out of the Community Foundation of New Jersey. Through that initiative, we work with houses of worship to provide vaccines in communities that are vulnerable. It's any faith, whether we're talking about mosques, temples, churches, meeting houses. We work with anyone that is willing to have us partner with them. We bring in vaccinators and we provide funding to those sites for helping to defray their costs of hosting these events. It creates a trusted setting for vaccines to go forward. We have interagency collaborations, the likes of which I had never seen in my 20 years with the Department of Health, which has been tremendous in making sure that we're working with partners around getting transportation to people to be able to get to vaccines, making sure that we are working on some of the other determinants of health, providing food assistance, providing housing assistance, all of the things that people will need to make vaccine a priority. Because if they're trying to figure out where they're going to live, they're not going to be concerned about vaccine. And of course, we have had a number of public-private partnerships. So what are things looking like? This depicts where we are with as of April 1st on Friday, these were the numbers or the percentages, I should say. The vaccines, 42 transmissions, I'm sorry, transmissions, 42.9% of transmissions to date have been within the white population. The white population makes up 55% of New Jersey's population in the state. Within the Asian population, 5.3%, Black is 13%, Hispanic is 21.4%, and you see the racial composition of our state on the side there. Unfortunately, deaths we have here, and 59.54% of the deaths have been among the white population. The deaths in the Asian population is 4.56. The percentage is 16.1 in the Black community, 13.85 in the Hispanic community. And there's notably a category of other, which is 5.1. And there's that 0.04 is unknown. What are some of the things that we have to do in order to ensure success as we move forward? Is we've got to look at access. Make sure that people have access to the resources they need to be healthy, whether you're talking about COVID vaccines, boosters, whether you're talking about the vaccines for children, you're talking about the preventive health services that fall under my umbrella. If you're talking about oral health services, ensuring that people avoid diabetes, heart disease, cardiovascular disease altogether. All of that starts with making sure that people have access to high quality preventive care services. Data and analytics will also inform what we do in public health. And so those who are evaluators, epidemiologists, you all are key to this work. Structural drivers and addressing xenophobia. We have to make sure that we're talking candidly about racism, stomping it out. It has no place in our society. And we're seeing that hate is always going to be around if we allow it. But we as a collective must be aggressive about ensuring that any form of stigmatizing people, of treating people as different, less than, has to be called out and it has to be stomped out. And then we have to ensure that we are involved in continuous quality improvement to make sure that the services that we are providing are timely and effective. Some of the things that we have been involved in, I mentioned a little earlier, the Uncompensated Care Fund that I oversee. There's a maternal care quality collaborative that's addressing some of the infant and maternal mortality issues within our state. The maternal health, child health block grant is also important in that regard. Our preventive health and health services block grant allows us to be able to look at a number of preventive health strategies to address the needs of New Jersey residents. We have the Healthy Women, Healthy Families initiative, which is specifically targeting the goals of ensuring that women, infants, and children are, are healthy in New Jersey. The First Lady's Nurture in J initiative is specifically targeting the infant and maternal mortality disparities. We have our cancer education and early detection program that falls in my shop, WIC, which is our Women, Infants, and Children's supplemental food program, SNAP-Ed. Faith in Prevention is a faith-based program to address obesity prevention and control. The Wise Woman program is a screening program for women to address and identify cardiovascular disease, and our oral health, nutrition, and counseling programs. So with that, I close, and I thank you so much for the opportunity to present today. I want to thank Mitch and also the Colleen, as well as Perry, for having me today, and I want to thank my fellow panelists.